Protein C deficiency is an hematologic disease condition Look at this picture. Shows that disease mechanism and signs and symptoms. CT scan for pulmonary embolism. Look at this. And Doppler ultrasound for DVT findings. Look at this. Detail going on. Introduction. Protein C deficiency is a rare but potentially life-threatening inherited or acquired disorder of the blood coagulation system. Protein C is a natural anticoagulant produced in the liver. Its deficiency leads to an increased risk of abnormal blood clot formation, thrombosis. Awareness and timely diagnosis are critical as untreated individuals may suffer from recurrent venous thromboembolism and severe neonatal complications. Definition. Protein C deficiency is a disorder characterized by the insufficient levels or dysfunctional form of protein C, a vitamin K dependent protein that plays a key role in regulating blood coagulation by inactivating factors via and villi, thus preventing excessive clot formation. Etymology. The term protein C originates from its classification during the alphabetical naming of vitamin K dependent plasma proteins. It was the third protein discovered and thus labeled with the letter C. The word protein comes from the Greek proteus, meaning primary or of first importance, reflecting its essential biological role. Epidemiology. Protein C deficiency is a rare disorder affecting approximately 1 in 200 to 500 people in the general population. For the heterozygous form, while the severe homozygous form is extremely rare. Occurring in about 1 in 4 million newborns, it is more commonly diagnosed in individuals with a personal or family history of venous thromboembolism. Types. A. Inherited protein C deficiency. 1. Type 1. Quantitative defect. Low levels of protein C. 2. Type 2. Qualitative defects. Normal levels but dysfunctional protein C. B. Acquired protein C deficiency caused by other medical conditions such as liver disease, vitamin K deficiency, disseminated intravascular coagulation, or warfarin use. Causes: A. Inherited causes: mutation in the PROC gene that encodes protein C. Autosomal dominant inheritance. B. Acquired causes: liver failure or cirrhosis, vitamin K deficiency, use of vitamin K antagonist, example warfarin. Severe infections or sepsis. DIC, disseminated intravascular coagulation. Certain cancers or chemotherapy. Risk factors: 1. Family history of thrombotic events. 2. Use of oral contraceptives or hormone replacement therapy. 3. Surgery or prolonged immobilization. 4. Pregnancy and postpartum period. 5. Active cancer. 6. Obesity or smoking. 7. Trauma or major surgery. Complications: 1. Deep vein thrombosis DVT. 2. Pulmonary embolism PE. 3. Warfarin induced skin necrosis. 4. Stroke or transient ischemic attacks. 5. Neonatal purpura pulmonis in homozygous or severe deficiency. 6. Recurrent miscarriages or pregnancy related thrombosis. Pathophysiology. Pathophysiology of protein C deficiency step-by-step process. 1. Normal protein C activation. Protein C is synthesized in the liver as an inactive cymogen. It is activated on the surface of endothelial cells by thrombin bound to thrombomodulin. Activated protein C APC with cofactor protein S inactivates clotting factors via and villi. This limits thrombin generation and prevents excessive clotting. 2. Deficiency of protein C. Inherited or acquired causes leads to related quantity. Type 1 for function, type 2 of protein C. As a result, activation of protein C is impaired or absent. 3. Failure to inactive factor via and villa. Without adequate APC, factor via and villa remains active. These factors continue to amplify thrombin production via the coagulation cascade. 4. Excessive thrombin generation. Uncontrolled thrombin formation leads to excessive fibrin clot formation. 5. Hypercoagulation states. The balance between procoagulant and anticoagulant forces is disturbed. This creates a prothrombotic environment, increasing the risk of venous thromboembolism. BTE. 6. Thrombosis and clinical manifestations. Blood clots can form in deep veins, DVT, lung, PE, or skin. In neonatal purpura fulminans. In severe forms, homozygous widespread thrombosis can occur shortly after birth. This stepwise breakdown explains how protein C deficiency disturbs normal coagulation and leads to thrombotic complications. Signs and symptoms. Symptoms vary based on severity. A heterozygous deficiency, milder form, recurrent deep vein thrombosis, pulmonary embolism, leg swelling, redness or pain, chest pain or shortness of breath. B. In homozygous or severe deficiency, neonatal purpura fulminans, severe skin necrosis and thrombosis in newborns, life-threatening thrombosis shortly after birth. Diagnosis. A. Blood test. 1. Protein C activity assay, protein C antigen assay. 3. Coagulation panel, PT, APTT. B. Genetic testing, identification of PROC gene mutations. C. Imaging. 1. Doppler ultrasound for DVT. 2. CT or P by Q scan for pulmonary embolism. Nursing diagnosis. 1. Risk for impaired tissue perfusion related to thrombus formation. 2. Acute pain related to DVT. 3. Ineffective peripheral tissue perfusion. 4. Risk for impaired skin integrity. 5. Anxiety related to recurrent thrombosis or diagnosis. Medical management. 1. Anticoagulant therapy, heparin, warfarin, carefully monitored, direct oral anticoagulants in some cases. 2. Protein C concentrate, used in severe cases like purpura fulminans or during surgery. 3. Fresh frozen plasma, FFP, temporarily provides protein C. Avoid vitamin K antagonist in neonates or during acute thrombosis until a hibernization is established. Nursing management. 1. Monitor signs of thrombosis or bleeding. 2. Educate on anticoagulant use and side effects. 3. Monitor INR if on warfarin. 4. Encourage mobility to prevent DVT. 5. Support patient during genetic counseling. 6. Prepare and administer protein C concentrate as ordered. 7. Ensure safe environment to prevent injuries due to bleeding risk. Treatment options. A. Anticoagulants, lifelong for severe cases. 2. Protein C replacement therapy during surgery or acute episodes. 3. Thrombolytic therapy in life threatening thromboembolism. 4. Vitamin K supplements if deficiency is present. 5. Surgical intervention, thrombectomy in critical cases. Psychosocial medicine. 1. Patient education and counseling regarding disease, nature, treatment, adherence, and genetic risk. 2. Support groups connecting with others experiencing similar issues. 3. Genetic counseling for families, especially before planning children. 4. Anxiety and stress management, guided relaxation, cognitive behavioral therapy, CBT. 5. Lifestyle modification support, assistance with quitting smoking, healthy diet, and exercise plan. Prevention. 1. Genetic screening for family members if known history exists. 2. Avoiding risk factors like smoking, oral contraceptives in susceptible individuals. 3. Prophylactic anticoagulation during surgery, immobilization, or pregnancy. 4. Monitoring during pregnancy with low molecular weight heparin, LMWH. 5. Education on early recognition of DVT or PE symptoms. In conclusion, protein C deficiency, though rare, poses significant health risk if not diagnosed and managed timely with appropriate anticoagulation, patient education, and genetic counseling. Individuals can lead relatively normal lives. Healthcare providers play a vital role in early identification, education, and management, especially during high risk periods like pregnancy and surgery. Lifelong monitoring and prevention strategies are key to reducing thrombotic complications and improving quality of life. Thank you. Have a nice day.